Welcome back to our rapid-fire explainer on surgical wound healing. We've got 10 questions, 0 pauses, and pure high-yield facts coming right up. So let's just dive straight in. Questions 11 through 13. All right, starting with question 11, which of the following is most important for primary wound healing? Is it A, a prolonged proliferative phase, B, a prolonged inflammatory phase, C, close approximation of wound edges, D, a contaminated wound, or E, a large gaping wound? And the correct answer here is C, time for an exam pearl on wound closure intentions. So primary intention requires clean wound edges that are closely approximated, with sutures, staples, or tape. This leads to rapid epithelial migration and keeps scarring to an absolute minimum. Secondary intention, on the other hand, happens when an open wound heals slowly by granulation and contraction, which definitely results in a larger scar. And finally, tertiary intention is just delayed closure after you've managed initial cleaning and contamination control. Hitting question 12 right now. Maximum immediate strength of a healing wound is reached in how many days? We've got A, 2 to 3 days, B, 4 to 7 days, C, 10 to 12 days, D, 13 to 18 days, or E, none. The answer you're looking for is D. Let's drop another exam pearl, this time on the tensile strength timeline. During the late proliferative phase, we see a really sharp rise in tensile strength right around days 13 to 18. This is driven mainly by type 3 collagen deposition. Then, over the next 1 to 2 years during the remodeling phase, that type 3 is actually replaced by type 1 collagen. The final strength plateaus at about 12 weeks, hitting roughly 80% of normal skin strength. Moving seamlessly to question 13. Which statement is true regarding wound contraction? A, infection decreases contraction. B, sutures provide strength for 5 to 7 days. C, epithelium attachment enhances contraction. D, caused by specialized fibroblasts with actin filaments. Or E, reduces wound size by 50%. If you guessed D, you nailed it. Here's your exam pearl on wound contraction. It occurs mainly in secondary intention healing and is mediated specifically by myofibroblasts. Now, these cells contain contractile alpha-smooth muscle actin. They start showing up around day 6, peak during the proliferative phase, and their main job is to physically reduce that wound's surface area. Questions 14 through 16. All right, question 14. Primary closure of an incised wound must be done within what time frame? A, 6 hours, B, 10 hours, C, 12 hours, D, 16 hours, or E, 24 hours. The answer is A, 6 hours, which brings us to an absolutely crucial exam pearl, the golden period. Your optimal closure window is strictly within 6 hours. After that, the risk of bacterial colonization shoots right up. Because of this, you really need to avoid primary closure in wounds older than 6 hours. Same goes for crush or blast injuries, anything with gross contamination, animal bites, or highly devitalized tissue. Right into question 15. Tensile strength of a wound reaches normal tissue by when? A, 6 weeks, B, 6 months, C, 8 months, D, 2 years, or E, never reaches normal. The correct answer here is actually E. A scar never reaches 100% of normal skin strength. The exam pearl to remember is that maximum scar strength firmly caps at approximately 80% of the original tissue strength. So even though the remodeling phase continues for up to 1 to 2 years, it is literally never going to exceed that 80% threshold. Question 16 coming in hot. Maximum collagen content in a wound occurs at A, 3 to 5 days, B, 6 to 10 days, C, 10 to 17 days, D, 17 to 21 days, or E, none. That would be D. Let's look at the exam pearl for peak collagen content. This peak accumulation happens in the late proliferative phase. It's really all about a delicate balance between the synthesis of collagen by fibroblasts and its degradation by collagenases. That exact balancing act hits the maximum tissue collagen load directly at days 17 to 21. Questions 17 through 18. Question 17. Which enzyme is required for bone mineralization? Is it A, alkaline phosphatase, B, collagenase, C, elastase, D, hydroxylase, or E, peptidase? Answer A, alkaline phosphatase. And for your exam pearl, alkaline phosphatase is secreted by osteoblasts. Its primary job is to get rid of inhibitors of mineralization, specifically one called pyrophosphate. By knocking out those inhibitors, it directly promotes hydroxyapatite crystal formation. Moving to question 18. Which factor delays wound healing? A, rich blood supply, B. Clean wound. C. Closely approximated edges. D. Low-dose steroids. Or E. Dorsum of hand wound. The correct choice is D. Let's break down the example on delaying factors. So local factors include things like infection, tension, ischemia, and foreign bodies. Systemic factors, on the other hand, include malnutrition, diabetes, vitamin C deficiency, and steroids. Steroids are a major one because they specifically delay healing by inhibiting both the inflammatory phase and overall fibroblast activity. Okay, question 19. Pay attention to the phrasing here. Which of the following does not disturb wound healing? A. Hypoproteinemia. B. Infection. C. Steroid therapy. D. Vitamin C deficiency. Or E. Blood transfusion.
The answer is E. Here's your exam pearl on systemic effects. We know hyperproteinemia leads to poor collagen synthesis. Infection results in prolonged inflammation. Vitamin C deficiency causes defective collagen cross-linking. A blood transfusion, however, does not directly impair the physiological healing process at all. Question 20. And we've made it to the final question, number 20. What is given to patients on chronic steroids to improve wound healing? A. Vitamin A. B. Vitamin B complex. C. Vitamin C. D. Zinc. Or E. Iron. The final answer is A. Here is your last exam pearl. We just talked about how steroids suppress the inflammatory response in fibroblast activity, right? Well, vitamin A actively reverses this steroid-induced impairment. It actually restores epithelialization and collagen synthesis, which perfectly supports those absolutely critical early wound healing phases. Which leaves us with a fascinating final thought for this explainer. If we can reverse systemic steroid impairment with a single targeted vitamin, how else might the precise manipulation of these early healing phases completely revolutionize the future of surgical recovery? Think about it. See you next time.